switched on your video now. It has been real pleasure listening to all of you with so much variety of cases, and I would definitely say that we learn a lot every time. Valsan sir was the first person who really kindled my interest into this hospital-acquired infection, and that's why I went on to know about it. And Paniraman sir always sees got the best, though he's in his private practice. Linsley sir and Anila ma'am, really you dropped. Thank you so much for the session. As usual, all the panelists were great. So now we move on to the next topic by Dr. Sudhakar. Dr. Sudhakar is the Secretary of Infectious Disease Chapter in Tamil Nadu, as well as he's a professor at Institute of Children's Hospital, Egmore. Now he's going to give fever in a child less than 3 months of age. So over to you, Dr. Sudhakar. Thank you, and Susan. Sudhakar, are you there? Dr. Sudhakar?
Sudhakar enga ponapla.
தெரியல சார், அடிக்கடி போய் காணாம போயிடுவாரு சார். அந்த டைம் காணாம போயிட்டாரு.
ஹாய்
வந்துட்டாங்க. ஃப்ரெஷ் அண்ட்
ஆமா.
ஆக்டர் மாதிரி வந்து உட்கார்ந்து இருக்கான்.
சார் 1 minute சார்.
So Sudhakar, do you need any more introduction for you, or I'll stop with this?
Wait. Okay. Okay, good evening to everyone of you. Can I go ahead?
Yeah, please go ahead.
Yeah, good evening to all of you. This presentation is not going to be very intense as like in the last panel. It will be very light actually. In my presentation, only the last 4 or 5 slides will be really important. It is like a climax social movie. To justify that, we have added other slides actually. So it's about the febrile infant and outpatient approach. So I have, for practical reason, in an OP, when a practitioner is practicing, how to differentiate these 3 children, like less than 30 days, 30 days to 3 months, 3 months to 1 year. This is not as per the ideal classification. It is based on my own experience. I'm talking everything from my own experience. So fever and outpatient, where is the confusion really happens? Many times parents will be bringing with fever or many symptoms. So out of 20 to 30% of our outpatients will have a carrying with fever. So the confusion is whether we have taken as a common harmless virus or less common severe viral infection or a very minor portion of the serious bacterial infections. We cannot overact thinking of less common SBI, or we cannot underestimate the occult severe bacterial infection against a simple viral infection. We always have the dilemma whether to start antibiotic or not. So fever with neonates. Again, I'm going to differentiate 2 things in the neonates also. First 3 days and 3 days to 30 days. So what is the definition of fever? We all know it is about the rectal temperature. Rectal temperature above 38 degrees, but axillary is all, but practical reason, we measure only the axillary temperature, which is considered normal between 36.5 to 37.5. Axillary is always 1 degree less than the 1 degree Fahrenheit less than the rectal temperature. So it is, again, coming to neonates, especially after 28 days or 30 days, it is not always the fever is indicative of infection. Even hypothermia is also an indicator of infection. So coming to a first case scenario, this is about a primary 30 years, conceived after 3 years, and anxious mothers after the LSES at 37 weeks, baby apparently normal, fed after 3 hours of delayed adaptation. Initially, the baby had on latching, so the hospital advised formula, but the mother is an educated mother, reluctant to start on formula. On day 3, the child developed a high temperature, settled after a while, and covered well for fever. And day 4, the mother noticed the jaundice, but there was no incompatibility with bilirubin 14. They started phototherapy in the hospital. The feeding reduced because the baby was most in the phototherapy, and mother wants the have the maximum time of phototherapy. The child developed high fever. They use the local measures like using fan for ventilation, all those things. On day 6, the child became lethargy, poor feeding, vomiting, and the child started on antibiotic, being treated as a sepsis. As the child sensorium worsened by day 28 and there is a huge weight loss, the child has been referred to our NICU. Here we admitted the child and we started on IV fluids and continued the antibiotics. Meanwhile, we started screening for that thing. But the point is, here we found out the urea to be 120, serum sodium to 170, CRP6, X-ray normal, and all the other results were normal, not everything in the borderline. So with proper fluid, the newborn showed very good improvement. So here, is it a fever? Now it's a very difficult to answer whether it is a fever or anything other cell. So now we have to understand there are other condition other than fever in newborn called hyperthermia. It is more common compared to fever. The incidence, it's not about the Indian data. I can quote only the Western data as per the books. 1 to 10% hyperthermia, whereas fever is only 1% temperature. In hypothermia, it may exceed 42 Celsius, whereas in fever, it is 38 to 41. So the point is, I don't want to go into full detail. So the hyperthermia is more common in newborn period, especially in the first week. It is more of due to dehydration or overheating. It's due to iatrogenic. Whereas fever, there should be any chance of infection like prematurity and pre-rupture of membranes. Here, hypothermia, the child will be well looking, where is unwell actually. And rapid response to the fluid management in hyperthermia, whereas in fever, it needs antibiotic, not the fluids can do anything. So we need to think about hyperthermia than fever, especially in the newborn babies. So the first 3 days, always consider overheating from the incubator, radio warmers, or ambient environmental temperature, maternal fever, maternal epidural anesthesia, phototherapy light, sunlight. Sometimes parents will be showing the baby in the sunlight actually, or maybe in poor feeding, it's due to dehydration and going to dehydration. Excessive bundling, this is also very often happen with our thing. Then comes your infection and CNS. So infection as a cause of fever at this stage, that means less than 3 days of is very rare, but still always observe and evaluate. So coming to 30 days to 30 days, fever and outpatient approach. So here, 20% of the newborn OP cases may present with fever based on the studies I'm quoting, Indian studies. About this fever, 10 to 12% of neonates have a serious bacterial infection. So that means almost 80 to 90% of the babies may not have a serious bacterial infection. But as a rule, we have to admit the child. There is no outpatient approach, but always look into history of the maternal fever, prolonged rupture of member, maternal culture positive for the group is streptococcal, and any history of genital. Never have, because these are things we often miss, and we'll start antibiotic, look for all culture, anything, but always don't forget to find out the reason. So infections in newborn easily outsmart our knowledge actually. So coming to 30 days to 3 months. 30 days to 3 months fever outbreak. Many times we come up, first confirm whether it is fever. Because many times we come across with the parents saying, Talaila sududu, virus sududu doctor, jorama irukku. This is the very common scenario people bring to us actually. Or like laryngomalacia, noisy breathing. Noisy breathing irundha chali pidichirukkudu, udambu thalaiyum virus sutittu irundhuchina fever irukkudu. Many times we forget to observe the child, how the child is dressed. They're full of sweater, especially during fever irukana innum konjam naal extra covering pannirupanga. So always unwrap. As per the WHO, unwrap, open the baby, uncover the baby, leave it for 10 minutes, then check the temperature. So again, head to foot examination. It's like blessing the child and get the blessing from the baby. So from head to foot examination. And always, whenever you think about, if it is a fever, always think about 3 I's: infection, inflammation, infiltration. The infection always plays a major role in this duration of 30 days to 3 months. The history to include illness in elder siblings and their vaccine. It is very important to exclude these things actually, because many times small children will come and kiss their siblings actually, and they will transmit the infection. It is easy for to understand how the infection in that previous elder sibling, so we can relate to that. And never forget about the occult infections like urinary tract infection, bacteremia, meningitis, arthritis, etc., etc. And arthritis especially hip. And many times we often miss these things because we don't have any other evidence for that actually. So common infections are viruses, especially influenza viruses, enterovirus, adenoviruses, and respiratory syncytial virus. First 3 viruses will present in a very mild, or whereas RSV will present with a severe bronchiolitis, not responding to our own our humidification or something like that. So they may need even foreign ventilation. Come on, next to the bacteria, pneumococcal bacteria, Escherichia coli, and staphylococcus. Considering our vaccination status in India, we are giving in the private sector only 7% coverage in the pneumococcal vaccination. Whereas in the government, it is going less than 2 kg. That was started now only for the last 6 months. So we are yet to cover the whole system of new babies for pneumococcal. So we have to expect the pneumococcal. We cannot expect a HIV influenza. So Haemophilus influenza nowadays we don't get because all the babies have been vaccinated with almost 97% coverage. Next, the E. coli and staphylococcus we never forget actually. Then another I want to cover, a 3 months baby on exclusive breastfeeding referred from Kanchipuram. This is a Kanchipuram GH is referred. Fever with 3 days and anemia, spleen palpable and thrombocytopenia. It's a well-thriving child, smiles back nicely, playful, feeding well, and referred as a suspected malaria, but not started on anti-malarial drugs actually. We admitted the child because the child has been referred from another hospital. The counts were normal. The hemoglobin was 10 milligram per deciliter. It's a microcytic hyperkalemia. And there is a thrombocytopenia. It is not an alarming. It is just on 1 lakh. The abdomen shows a mild splenomegaly and other values are normal. And there is no evidence of any occult infection based on the culture and everything. How to go with this case actually? So my PG says that it could be in clinical malaria because there is a fever for 3 days. There is anemia, spleen palpable and thrombocytopenia. It may be a rickettsial infection or it may be a malaria or it could be a simple viral infection also. So the thing is, the message I want to convey is whenever in my practical experience, whenever we send for an ultrasonogram, the radiologist always gives splenomegaly. But the thing is, we always need to understand a palpable spleen is found in most preterm babies and 30% of the term infants. A spleen tip is still palpable in 10% of the infants up to 1 year of age and 1% of the children up to 10 years of age. It is always as per the spleen size. This measurement I have given, but we have to get within measurements that's cutoff levels from your own radiologist actually. This is the thing given in an article. Splenomegaly, anything more, splenomegaly has to be considered when anything more than 6 centimeter at 3 months or 7 centimeter at 12 months, 9.5 centimeter at 6 years, it goes on. So the point is, just because you feel spleen, don't take it as splenomegaly. Just because there is an anemia, because almost 65% of our children are having anemic. Almost 65 to 8, 70% of our mothers are anemic mothers only. So we need not, but this child, we didn't do anything. We simply observed the child. The child was discharged without any antibiotic. So another case of drink, that was a simple case. Now I'm going to the next case. Danyasri, 2 months, 10 days, female baby. It's a second born non-sconty. Fever with 1 day with irritable cry and breathing difficulty. Apparently normal 2 days back. And there is a thing, there is a development, the child developed a erythematous rash involving the face, trunk and limb. The mother went to the nearby primary health center. Baby was treated with oral medications. After the first day, the child rash worsened. So the baby admitted under our care, lethargic, refusal, incessant cry, bad CRP, rashes. The striking thing is about the rashes. No other findings actually. There was not much past history because baby is only a small baby actually. So the examination, there are the edematous lens, skin mottling was there, flushed face, trunk, palms and soles. So all the other things are there. Only thing is effortless tachypnea and a soft splenomegaly. So the investigation saw increased total count, a platelet with 4.5 lakhs and an anemia. The CRP is 12 and LFT, RFT normal. And there was the day 2, there was a persistent tachycardia, continued fever spikes, shock did not improve with the fluid bolus and ionotropes continue. We upgraded without knowing what to do. We were also in a panic. Actually, we started to increase the antibiotic coverage. So we started meropenem. But still the rashes started progressing and it started going into a gangrenous level. PTA, PDT, INR was elevated. D-dimer was almost 1,920 and we started a FFE transfusion. And meanwhile, this is the case of the gangrenous and changes, erythematous change and a gangrene, the child. And as the hemodynamics baby improved, fever spikes subsided, but the skin changes persisted. So we refer the child for the hematologist's opinion to ICH, where all the cultures were normal, repeat CRP were normal. And finally, the child, because the rash was persistent and no culture was there is no proof of any infection. They thought about congenital anticoagulant deficiency was suspected and protein C and protein levels tested in both parents. It shows the mother having reduced protein S and C and father having reduced protein S. Finally, a diagnosis of purpura film. So we need to be very alert in our OP when there is a change. See, always what I want to convey here is whenever you're seeing a baby with fever or something, when you are not able to find out the focus, always please ask the baby to come back without starting any antibiotic. If the child is hemodynamically stable, we need not rush with any antibiotic, but always ask the patient to come back. Case scenario 3, baby Mitra, 3.5 months, had third dose of Pentavac vaccination, developed fever after 4 days, had been treated with antibiotics in private for 3 days, and admitted on 7th post-vaccination day with 3 days of fever. The vaccination site showed small swelling. There was no induration, no pain, well-thriving child. During a febrile period, taking feeds well. There was no foci of infection history and examination. So it has been registered as an adverse event following immunization. The parents were telling the VHN that because of our vaccination only everything happened, but the counts were normal, CRP normal. Anyway, for the sake of safety, we started an antibiotic. During examination, the baby was kept in the mother's lap. Nobody noticed that actually. There was a restriction of movement on the hip on the vaccinated leg. So now meanwhile, the blood culture we received the blood culture report. It shows Klebsiella oxytocin, which is a gram-negative, which indicates as a pathogenic bacteria. We need to rush with an antibiotic. But the point is, I'm not able to convince with the way the child is presenting. If it is a septicemia, the child should not be present like this. A well-thriving child taking feed very well in between that, except for a restriction of movements on the left side. But meanwhile, I'm not convinced about the injection abscess also. So ultrasound hip and MRI hip and knee joints were not done. Everything showed normal except for a synovial thing. Finally, it is managed as a transit synovial after stopping the antibiotic and continuing with only. So the point is, when with paracetamol, it is become normal. The point I want to convey here is our clinical examination is more important than your other results actually, because the initial ultrasound was in a confusing state. So we did an MRI and everything find out. And I went through the journals. There was no transient synovitis following immunization has been reported, especially in the infants, except for rubella vaccine and flu vaccination. In certain few journals have been, that too only adolescent adults. There was no case reported in the young infants actually. So we are not able to explain these. It may be a simple viral synovitis. It's a coincidence actually. So 3 months to 1 year. A case scenario, 6 months baby with fever for 2 days with running nose with fever spikes ranging between 101 to 103, no afebrile interval as the parents are very anxious about high temperature. Child was started on oral, sorry for the spelling mistake, was started on oral antibiotic as well as CBS was ordered. The complete blood count showed total count 14,008 with neutrophilic predominance and a normal plate count with a CRP borderline 6 nanogram. The point here is, we are not supposed to, we need not panic. See, the point here, the case is a simple viral infection. Consider the duration of fever. It is just a 3 days, less than 3 days. Whenever you go for a fever, it's less than 3 days. Yes, the neutrophil is going to be predominant. We need not take it as a bacterial. Whereas other than that, when we don't have any culture positive and there's no any foci of other infection other than a running nose, very well we can manage the child with paracetamol. This is a case in my own practice. I managed only with paracetamol. The child is fine actually. Then again, another child, a 2 years child admitted 2 days back, 2 years old male child, high-grade fever for 3 days, no other symptoms or signs of any foci of infection, WC normal, the MP-cod test positive, the child was managed with syrup falcigo, injection amikacin, injection subtraction in just 3 days. This was in private practice in Chengalpattu district. And after getting admitted, I stopped everything in our and simply observed. It's found to be very simple because MP-cod test should not be been done for this child. First of all, it's a rapid test. You should not rely on the rapid test actually. Your clinical knowledge, because sometimes investigations misguide us actually. This child has been managed without anything and finally went very well. Case scenario 6, this is a 6 months female child Nila present with high grade of fever and diarrhea for 7 days, treated as outpatients. I only started oral cefixime, started me of persisting fever and diarrhea. Still fever was persisting, as I don't know how to go with that. I don't want to take risk. After 7 days, I admitted the child in KKCTH under Dr. Janani madam, and madam made the clear diagnosis of multisystem inflammatory syndrome in children, MICC. So with the COVID and immunoglobulin positive, nicely managed, the baby is very fine actually. So we need to think that there is a wide varied presentation of fevers will be come to our OP. So we need to see everything with wide eye open actually. So there are a lot of, so how in a practical, I have talked about so many things in a very short time. So it can be a simple viral infection, or it could be a purpura fulminans, it could be MIC. So a fever can start with the, but we need to follow up the child in a meticulous way. Never hesitate to ask the parents to follow the temperature chart, teach the parents to follow temperature chart, ask them to come as much as possible. Then comes here, there are a lot of criteria. When you go to the textbooks, there are a lot of ideal things are there. There are Boston criteria, Philadelphia criteria, then comes your Pittsburgh criteria, Rochester. So a lot of things are there actually, especially for less than 90 days baby. So what is the problem with this? That you go through the investigation, they always need an investigation. But practically in the Indian setup, they won't hesitate, they will be hesitating to give a fees for you, 100 rupees or 200 rupees. If they how come they can do a complete blood count, urine culture, urine retain, and another biggest problem is most of the criteria require cerebral spinal fluid. Lumbar puncture is very much important to fulfill these criteria. So what is the problem in Indian? What is the difference between the Western? This slide, I thank Dr. Tangavel sir for sparing this child from his presentation. The Western environment and Indian army is totally different. The age and blood culture based is our Western literatures. So we should have our own set of blood culture results and age based diagnostic. Only institutes like Childress, CMC, Coimbatore, they are doing the studies actually. I think every institute have its own pattern of infections as well as culture sensitivity pattern. And uniform standardized approach from home care to emergency room, ward, critical care, that's a well-connected network thing, but we don't have anything. We don't have a uniform standard for our own investigations and antibiotics. So we need to improve of that actually. So Western protocols is very difficult to apply in our setup because it needs lab support, which is inaccessible, many times unfortunately unreliable and very expensive and not in convention in our setup. And the common illness like it differs from them because their vaccination rate is totally different from vaccination pattern as well as the disease pattern is totally different from Indian setup. We need to think more of dengue, malaria, enteric, leptospira, and of course, I don't want to forget the scrub typhus. And after going to Chengalpet, I come across like a surplus of scrub typhus. And when applied, many bring a new perspective relevant to our own. So we start to think about our own thing, and we need to document every case of fever with clinical findings and investigations. And this, I'm going to come to the end that this is the literature review. Our Indian pediatrics in 2017 has come out very nicely about that. This is about the approach of a child with fever in an emergency room as well as an OP. So here I have taken only this, a well-appearing child coming with fever to then our OP. It's either your OP or emergency room OP. So they have categorized into three things. So let us consider the first three things, 29 days to 90 days. That's up to first 3 months. Even Indian pediatrics, IAP recommend a blood test of complete blood count, quantitative CRP. It is not just the qualitative, it is quantitative CRP. And another thing I want to mention always a serial of quantitative CRP. Then the band cells, we never ask for band cells. It is very easy for the pathologist to give it. Eye touch, immature and total cell ratio. It is again going to be a very simple thing. Toxic granules. Yes, again, it is anyway, whenever the pathologist is going to say, they can mention about the toxic granules, vacuolization in WBC, blood culture. And unfortunately, here also we need lumbar puncture. To be an ideal, yes, we need to have a lumbar puncture and X-ray and urine. Of course, except for the LP, all the other investigations, we can very well do it actually. Coming to the 28 days in neonates, I always tell better admit the child. If there is a fever less than 20, never take risk, better admit the child and evaluate the child. And 3 months to 2 years, or there is a partial evaluation for severe blood tests like complete blood count, quantitative CRP, band cells, IT ratio, toxic granules, vacuolization, RBC, blood culture, urine routine and culture. And we need to inculcate the culture of doing culture. Dr. Gunasingh always insisted this: never do start an antibiotic without doing any proper culture. And we need to sensitize our own parents of doing the culture. We never start, better not to start any antibiotic without doing any culture. Coming to the, so what is the thing when I talk to Thangavelu sir, what can we do when the criteria like in Western criteria cannot be applied to that? So what is the criteria? Why don't we develop a criteria? That's what sir gave the reply. There is a criteria. It's simple pediatric assessment triangle. So here
Sudhakar, you need to hurry up. You're already
I'm in the last slides. Okay. So it is about the alertness, breathing pattern, and circulation. So we can go to the foci. If you have to look about the foci of infection with this. Okay. So the lessons to learn is parents may be panicked, but not their doctor. A proper history, proper examination, proper communication to the parents is the gold standard of management. If the child has received an antibiotic within prior to 3 to 7 days, because of the long half-life of antibiotic in young infants, administration up to 7 days prior to evaluation may mask the sign and symptoms of invasive bacterial infection. Be alert about it. Never take culture from sample from a non-sterile areas. Reports may be contaminated. Never just follow the results. Never start antibiotic based on acute phase reactants. Fever without foci. Please do a maximum examination, moderate investigation, and it makes you to give a minimum prescription. And evidence is always better than experience alone. Thank you every one of you for the opportunity.
Thank you, Sagar, for your excellent presentation regarding febrile in the infant outpatient approach. It is one of the excellent presentation. Next 1 hour, we are having panel discussion on playing with labs. I want to introduce our moderator, Dr. Arun Bansal.